Hello, I'm Jeff Bennett, the CEO of Higgy.
Hello, Linda Mayhew, Senior Director of Clinical and Customer Success with Xander Cardian.
Good morning, Asif Ali, Dr. Asif Ali, cardiologist from UT Medical School, and welcome to this session.
Hello, my name is Maurice Nassim, and I am the President and CEO of CloudStream Medical Imaging.
Good morning. Ben Green, Senior Vice President of Services at AliveCore.
Morning, AJ Blood, cardiologist at Mass General Brigham.
Good morning, Randy Foraker, Professor of Medicine at Washington University in St. Louis.
Good morning, I'm Ido Paz, a cardiologist at White Plains Hospital, and I lead medical affairs at Hello Heart.
Good morning, I'm Zane Arp. I am the Division Director for the Division of Biomedical Physics at the FDA.
Good morning, Francoise Marvel, cardiologist at Johns Hopkins and co-founder of Cori Health. So thank you to the panel. Please have a seat and we'll begin. So thank you for being here for our first session. I'm delighted to provide the opening remarks for creating a scalable, sustainable business model with remote patient monitoring and digital therapeutics. My disclosures. The Harvard Business Review recently published a really provocative piece on how can we tap the full potential of remote patient monitoring and digital therapeutics. And the reason I want to emphasize this is because we have incredible talent in our American Heart Association Innovators Network. And with all of our efforts combined, we are going to be able to achieve these incredible outcomes that can come from RPM and digital therapeutics. First, optimizing the way that we deliver healthcare services, being able to advance health equity, changing the paradigm between clinician and patient so that when visits happen, when we have encounters, when we see a patient, we're doing this in the context of data-driven and treatment-focused discussions. And of course, ultimately, as we stand at a precipice where we face challenges with an aging population, with an overwhelmed and overburdened healthcare system, where we have a mass exodus happening within our clinician and our care teams, we have to improve health outcomes, and we need to be able to save the economics of healthcare by thinking differently about care delivery. When we think about the three phases of creating a scalable and sustainable business model, Chakrabarty et al. Really put together, I think, a 1-2-3 approach for telemedicine, RPM, and digital therapeutics. It starts with what's the value? Define and identify an addressable problem. Make sure you know the market size is going to be amenable to what you want to do. And then what's the value to stakeholders? Once you get that value proposition nailed, then go on and figure out how are you going to create that value? What are the operational resources you need to deliver that RPM for heart failure patients? To deliver that channel, are you going to be working in the outpatient clinic? Are you going to do the acute care? And then how are you going to build relationships with the customer, whether that's the end user and you're doing human-centered design like some of the work led by Dr. Zakazde and Dr. Spalding. It's how do you take what you're learning and apply it to your product? And ultimately, which every company here has to really demonstrate, is that you can create value, you can create profitability, and you know that the cost structure that you're offering with your product is fitting within the landscape that exists. And when you think around growth potential and scaling, that you can meet the demands of the target population that you aim to serve. Now, there's going to be challenges. We're all in this innovative space, and I'm so excited that our panel is going to be addressing some of these challenges and how to really mitigate them and how to overcome them. So maybe when you have your value proposition and you go to value creation, you realize, the user expectations and experiences, there's some dyssynchrony here. How do we fix it? Is this innovation actually needed? I really love the idea, but is it really needed? And as you move from value creation to value capture, is your pricing model right? did you discover that perhaps the pricing model's a little bit off, a little too high, or maybe even a little too low? Has a competitive landscape changed? As AI and others begin to build, you're competing with Google and Bard. You've got, what's Apple up to? We know ChatGPT. There are all these things. So what are some of the challenges that you can address there as the landscape changes? And then are you prepared for growth? If your idea takes off and you're at another level and you've got 300 customers knocking down your door, are you ready for those kind of growth challenges? Ultimately, when we were scaling and working within Corey Health, we found that turning to stakeholders and understanding the problem points and developing and adapting, working with policy changes is critical. Clinicians, industry partners, payers, the American Heart Association, being part of this Innovators Network, being part of the CHTI is critical. And we put our minds together working with Apple, payers like Aetna. Pat Dunn led the American Heart Association, PCR for CHTI, and the incredible innovators, clinicians and engineers at Hopkins really coming together and try to figure out what's the right path forward. And we put together a roadmap on how we can scale tech-enabled preventive cardiology. And I bring this up just to set the landscape for discussion because we need to share our learnings with each other so we can not just experience this in silos, but synergize and grow together and become successful. And so where we felt there were really key points is cross-sector partnerships, not sticking within healthcare, not sticking with just industry, bringing it all together. Understanding what the payer must-haves are before you launch into a product development. Being a champion for health equity. Making sure to bring in AHA guidelines and really drive policy change. And ultimately learn from billion-dollar companies how they succeeded. Now, my most important role here is to just highlight again the incredible panel members and showcase leaders that are going to be here. So Dr. Forker, again, Director of Population Health Informatics and Institute Informatics at Washington University, will be emceeing and leading this, really excited. Linda Mayhew will be, she's our Senior Director of Clinical and Customer Success at Xander Cardian. Friend and colleague, Dr. AJ Blood, bringing in not just his clinical, but also incredible trials that he's led and expertise. Dr. Ali, again, just a member of Health Tech Advisory, cardiologist, but bringing a lot of experience with innovation. And then, of course, we have industry leaders, Dr. Paz coming in, SVP of Hello Heart, and just wonderful, going to have great discussions. And then for our showcase, stick around. I had a great discussion with Maurice before this panel started. He brings in geology, geophysics experience. And so we were talking about how geophysics and mining for that oil and how we mine in cardiology for the culprit lesion or the atherosclerotic disease can have a lot of similarities. Dr. Ben Green from AliveCore, really excited to get insights and feedback, and Jeff Bennett, CEO of Higgy, again in that CEO role, really getting a lot of experience. And then hearing from engineering and FDA with Drs. ARP, and then John Anderson, again, that understanding of sales and commercial lead with BioBeat. So just, again, I want to compliment and thank the expertise that's on our panel, and it's my privilege to join them and have you begin the discussion. Thank you so much.
Oh, I'm going to stay perched right here for the discussion so you all can make yourselves comfortable in those chairs. Very good. And as the panelists are getting comfortable, what I would like to do is just briefly introduce myself and let you know what my expertise is in this area. And then I'd like to go down the line and hear more about the technical solutions that have been deployed by the panelists so that we have a nice foundation for the discussion today. So one of my roles at Washington University is to think about digital transformation and the intersection of not only the technology, but also the people and the processes that get it done in terms of implementation science. And so one of my success stories to date is implementing a machine learning algorithm at the point of care to help determine which patients are appropriate for end-of-life discussions and palliative care referrals. And that's being scaled across our health system, and it's being commercialized by our group. So that's kind of a beginning to end kind of success story that I have had the honor of being part of at my institution. And with that, I'm going to hand things off to Linda to tell a little bit about where she's coming from in terms of this discussion.
Thank you, Brandy. My name is Linda Mayhew. I'm the Senior Director of Clinical and Customer Success with Xander Cardian. I'm a registered nurse by background, and I joined the kind of tech world, I guess you could say, almost 2 years ago now. I come from a background of primarily long-term care in the administrative space in Ontario. And I think what's been really powerful about my work is joining a company called like Xander Cardian, where we have the first commercially available Class 2 medical device that uses radar to monitor vital signs continuously and autonomously.
Hi guys, my name is Ido Paz. I'm a cardiologist at White Plains Hospital in Westchester, New York, where I practice clinically. And aside from that, I lead medical affairs at Hello Heart. For those who don't know about Hello Heart, it's a digital therapeutic which consists of a mobile app and a connected blood pressure monitor that allows members to track blood pressure, cholesterol, activity, other heart health markers. It allows members to consume digital coaching around cardiovascular risk factor reduction. It allows members to generate reports that they can share with their clinicians so that data could be used to improve the care that they're receiving. And really appreciate the invitation to be on the panel.
Again, AJ Blood. I'm a cardiologist at Mass General Brigham, and I'm a clinical researcher. We use team-based models of chronic disease management across the cardiovascular space, hypertension, hyperlipidemia, heart failure, to try to improve outcomes, and really excited to be a part of the panel and talk through how we can build and scale these types of interventions to help our patients.
Asif Ali from UT Medical School, but also that's on the academic side. And on the industry side, Chief Medical Officer at Cardio, which is a digital remote monitoring company that looks at RPM and CCM. And part of my role as their Global Chief Medical Officer is to look at new opportunities in healthcare and where we can transition where there's needs. And one of the big areas that I'm leading with the company is in digital cardiac remote rehab, where it's very underutilized. And I'll be giving a talk later this afternoon on that as well. Thank you.
Thank you all. As you can see, we have great expertise on the panel today, and a lot of my questions where I'm going to be coming from is really in the area of implementation science. So a lot of the work that I do is around effectiveness and implementation studies. So a hybrid study to look at not only if it works, but why it works or why it doesn't work. And so a lot of the questions that I'm going to be asking today are really around the adoption and the reach and the implementation and the maintenance or sustainability of these types of technologies in practice. And so my first question, we can change things up here and start with Asif. My first question is around the biggest factors that you see that providers of remote or virtual services need to consider when evaluating tech solutions for their practice.
Yeah, that's a big challenge that I think we're all trying to fix. So it's a great question. So there's so much in that question. I mean, everything from health disparities to just access to, I think we've had a lot of talks even in these sessions in health tech innovation about making products that are, we looked at human computing, making it easier for consumers to consume, making the technologies almost seamless. Because right now, if you make patients go through even 3 steps, it's probably going to fail. It needs to be a one-step solution. They place it on. And I remember doing a talk on iHeartRadio talking about that the future of digital tech is where patients are collecting data without even knowing about it. For example, just sitting in your car, you get a weight, you get a pulse ox driving your car. We need to make it where it's so seamless that as a consumer, we're actually collecting that data. So the difficulty in all of this is getting it paid for from the physician standpoint. I'm in the trenches. I do this every day. I run studies and trials, and I think part of the issue is just getting the payers and the physicians and the patients all in the same arena and understanding all the healthcare disparities and costs and connectivity that goes along with it.
Absolutely. And I'm hopeful that some other members of the panel can build on that discussion of, return on investment and how we document that we're making a difference with these tech solutions. What are your experiences in that regard?
Yeah, absolutely. So, one of our biggest challenges is convincing medical directors or benefits leaders that our solution is worthwhile, that there is a strong return on investment. So what we do is we routinely do claims analyses for employers, looking at the actual medical spending of members on Hello Heart compared to those who don't, and we routinely see cost savings. So we've published one with the Validation Institute, which is a third party that does cost savings analyses, where we demonstrated that within 1 year of using Hello Heart, members were able to reduce medical claims by around $2,300 or 19%. And I think in some ways cost savings are even more impactful to a lot of the benefits leaders and medical directors than clinical outcomes, because the return on investment is very, very clear. That doesn't mean that you shouldn't also publish on clinical outcomes. We spend a lot of time doing clinical research. We've published in JAMA looking at 30,000 Hello Heart members showing a strong blood pressure reduction. But the financial outcomes are key, because ultimately the payers, whether it's a self-insured employer or Medicare Advantage or a government entity, is going to be really interested in knowing that the money that they're investing is going to translate into cost savings.
It's funny that you bring that up, because that's been a really hot item that we've been talking about quite a bit at our company, is just, how much value do the clinical outcomes bring? Now, obviously, as clinicians in the room, the clinical outcomes are the be-all, end-all. But at the end of the day, we know that unless there is revenue generation and all of those other, or cost savings or whatever it might be, that it's not going to go anywhere, right? So I think that's such an interesting component. And I know, especially in the health tech space, there are so many competitors and innovations happening so fast. And I think it's easy to be undercut by the next biggest, best thing, right? So I think in some ways you got to stay true to your North Star, and you got to be committed to, at the end of the day, bringing the best clinical product. And then you just have to find out how to make it fit in the environment that you're working in. So thank you. Yeah, that's really funny. We've been talking a lot about that.
Yeah, so we're in a very interesting period. As this technology is really getting out there, patients want it, providers want to use it, but I think the compensation models still don't really make sense, truthfully. RPM and CCM, the number of measures or the amount of time you spend should really have nothing to do with what you're being paid for, in my opinion, right? We should be paying for performance. We should be paying for clinical outcomes. We know that's what really makes a difference at the end of the day. And a lot of these analyses that are comparing, they're important to do, but if you're comparing somebody who picks up the phone and participates and is using the app or the tech or the device versus those who don't, that's not a fair analogy. Those are not the same patient populations, right? You're getting a healthy, engaged, active participant versus somebody who's not, who we know is going to spend more money in healthcare resources in general anyway. So I think what we really want to do is start to align those incentives and make sure, we're shifting from this, episodic, pay for doing something model that we're used to. We're shifting slowly to pay for performance. Show me the outcomes, show me the data that you're actually making a difference, and these health metrics are going to improve and their outcomes are going to improve because of that, to eventually value-based, which I think is where we're all kind of projecting things are going to be in the coming years. But again, things like hypertension, like lipids, that doesn't always pay off in a quarterly cycle. It's a little tougher to make that business case when your outcomes are going to be 5, 10, 15 years down the road. So making that investment is a little bit tougher of a sell to a payer or a benefit manager who might say, well, my quarterly returns are not up, so thanks for your service, I'm moving on to the next.
Mm-hmm.
And just to add that, because AJ and I were talking about this, I mean, if you think about the 20-minute necessary time that you have to do per month for RPM or CCM, it really hampers actually technology, because if we look at advances in AI where we can do these with seamless, even AHA has its own care pathways, and bring those pathways in an AI type of fashion, those are results that can be done in a much quicker, scalable way to the masses, rather than a timed 20-minute with a nurse practitioner or HCP. So it actually hampers innovation if we don't push for outcomes rather than just a time period, right?
Well, and not only that, but it also excludes, a portion of the population that would really benefit from the service, right? So a lot of the settings that we're working in right now are in, post-acute and skilled nursing and those types of settings where, if a patient isn't there for 16 days, then it's very hard to actually be able to, for an RPM provider to actually want to be able to service those patients, even if they want to, because it's just not financially manageable, right? So those patients that actually would benefit the most are naturally omitted from that opportunity.
And I think these barriers are really relevant because what we've seen is that the greatest uptake is in the owners of the risk. So whether it's a self-insured employer or a capitated health system or a Medicare Advantage plan, because there you're not necessarily beholden to the ICD, the CPT codes. If you generate cost savings, that's what they're most interested in. So it's a really interesting observation that pans out as we see in kind of the commercial setting.
And before we even get to these types of conversations, we have to have individuals who are willing to use the technology and test it for us. And a lot of the workflow considerations that Linda mentioned earlier can hamper real-world uptake of these technologies. So how have you all engaged clinicians and patients to actually use the technology so that you can make it better and even more usable?
I'll go first. This is an easy one for us because our device is completely autonomous. So there actually is no engagement required on behalf of the patient. But that being said, we have found that is a really powerful thing because if you've got a device that you don't have to manually input information or you don't have to charge or you don't have to, kind of take care of every day, then we get a huge amount of data and we're not dealing with compliance challenges.
Yeah, I mean, it's interesting, leaning on the best clinical guidelines, that's table stakes, right? That's why I spend a ton of my time looking at the different workflows, the clinically based workflows in the app and ensuring that they follow best practices, just like a lot of the guidelines we lean on are from AHA or other kind of premier societies. But that's not enough to create a highly engaging product. So, other tools that we use a lot, data science, machine learning, those used to be nice to haves, but now I really think they're must haves, and we leverage those to create a highly personalized environment so that each member is really getting an environment that's directed at their needs and at their feedback. If they tell us a particular feature is helpful, we're going to try to feed them more of that feature. And then I think ongoing work with the medical, we have medical advisors. We speak a lot with medical directors, getting their feedback, showing them the product. And of course, our most important feedback comes from our members, those who are actually using the platform, who tell us what they like and what they don't like. And we listen to that and we try to react to that.
So one of the ways that, I think in technology, it's always making it easier, faster, better. And it's both for the patient and for the clinicians who are prescribing technologies. And so one of the areas that we're working on is in transitions of care, because I think that's the easiest area to really get people to start using digital health. So for example, just going back to cardiac rehab, someone has an MI, someone has a TAVR, someone has a mitral valve replacement, and even in heart failure, which is an indication for for cardiac rehab in general. So that transition of care, that's a great area to look at prescribing digital health, and that's one of the initiatives that we're actually working on now.
And just to briefly add, I think a lot of what we do in this space, hypertension in general, not super symptomatic. Hypercholesterolemia, generally not super symptomatic. Our patients aren't complaining, my knee hurts, my back hurts, I really want to be part of this. So passive, engaging, gamification, these things that make it such that your patient is a partner in this, I think are really key to getting them to be a participant in their health.
And I'm curious what you're hearing from patients who are using these health technologies. What do they like and what don't they like?
So we do a lot of patient engagement. There's various time points where we'll reach out to a patient. So for example, if we launch a new product feature, last year, we launched a feature geared towards women going through menopause, talking about the increasing cardiovascular risk associated with menopause. So whenever we launch a feature, there's always some post-feature feedback that we're soliciting and we're acting on. And overall, I think patients like very positive messaging, reinforcing messaging. They don't like, you've been doing bad, you gained weight, your blood pressure stinks. They want positive, reinforcing messaging, and that's what we focus on. It's very human-centric design. No matter how good a product is, no matter how much it leans on the best clinical protocols, if the patients aren't using that solution, you're not going to see neither the clinical nor the financial outcomes. So it's all about human-centric design.
And as AJ said, I think one of the areas in tech that I don't think we've done a really, really great job is in gamification. Getting people, it's all about utilization and decreasing attrition rates. And not to plug in any companies, but if you have a Starbucks app, they do a really good job of giving you stars and things of that nature. And I really hope, I had gone up to Bupa Health in London, and we were working on a project on incentivizing individuals, and I believe this is what it's going to take. You have to incentivize patients to use your product, and I believe one of the biggest ways to do that is through monetary incentives. So, I would hope insurance companies would look at the data that we're all of us are collectively trying to work on in a population health system, and really say that, look, if don't ding individuals for not being part of it, but if individuals are willing to track, for example, a pedometer or their weight or their blood pressures, and create a system where we're doing lifestyle as medicine, and they're looking at preventative services, and they're ticking all the boxes. I'm wearing my, my 8 here for the American Heart, and they're following, the lifestyles that the American Heart's pushing out. Then incentivize the patients to get maybe a reduction in their insurance premiums if it hits their pockets. And insurances, by the way, would love patients to be healthier, because at the end of the day, it costs them less. So we have to incentivize models for patients to be engaged and to utilize and capture the data so that we can make actionable items on that, and then gamify it so that they actually enjoy using the technologies that we're producing.
One thing we hear a lot from our patients is that they don't like whatever health app or device or tech they're using to be completely dissociated from their doctor or their general health care. So I think a lot of these perpendicular, non-integrated solutions, patients find frustration when it's not easy for their doctor to see or know that. And I'll say, I need another platform or portal or something to log into. Like, I need another hole in the head. It's just not, if you're not making it easy, both for patients and providers, to use this data, to integrate it, to consume it, or generate it, you're not going to get a lot of value out of it.
Thank you. Just to add to that, I think that's kind of an interesting question that, as a tech developer, we're struggling with, admittedly, because we want the customers are asking for access to the data. They want to see, or they want to be able to track what mom is doing or dad is doing. But for us, it's always a balance to say, how do we give you information that is digestible and understandable and relevant to what you as a consumer need, and then give that same clinical level information or detail to your providers, so that, obviously we can't share, they overlap somewhat, but it's not that simple. So how do we create a platform that can be easily used and valuable by both parties?
Yeah, I just want to react to what Asif and AJ said. First, Asif, to your point about gamification, we have a product manager who actually comes from the video gaming industry. Exactly, I agree with you 100%. Gamification is key. A nice example is we have a medication tracking feature, and if you track your meds, you get rewards for that. Congratulations, stars. You do 7 days in a row, you get a special kind of gamified reward, and it's actually quite effective. It actually leads to significant increase in uptake of this feature around medication tracking. And then AJ, your comment about clinicians is a great one. We've thought a lot about how we plug back in. Members collect really robust data on our app, right? Blood pressure, they can connect their Apple Health or Google Fit, so they have activity, they have weight, medication tracking, digital coaching they've consumed, really robust information, and we want to get that back in front of the providers. So, we have a clinician report that members can generate. We tried to make it as efficient as possible because we know you can't get it back into everyone's EMR because everyone's using a different EMR, but we've tried to solve for that by creating a highly efficient clinician report. And the thing that's interesting about that is we find in our population that some of the underserved population. So our app is available in English and Spanish. The Spanish-speaking population uses it a lot more than the English-speaking population. That clinician report, sending it to their providers. Older patients, older than 65, tend to use that clinician report more, and it's really interesting seeing which populations are using that feature to try to really have their provider have access to the data that they're collecting on the app.
And I'd love to hear more about sustainability and also scalability. So you've talked about gamification as a possible way to sustain use and to keep users engaged. I'm also thinking about solutions that work perfectly locally. And I'm hearkening back to the mortality algorithm that I was telling you about at the top of this session. It works beautifully at our institution, but now we're commercializing it and scaling it to other institutions. And there are challenges around that in terms of different EHRs and different sources for those data. And really, the pre-processing may have to start from scratch in some of those locations. But I digress. I'd like to hear more about your solutions for sustainability and scalability so that we can keep these tech solutions as solutions moving forward.
Kick this one off. I think if you're looking at sustainability and scalability, you have to think and you have to work smarter, right? So a lot of the technology that's coming out is obviously very powerful, right? But how do we use that in a way that's really intelligent for the actual clinicians or whoever's doing the analysis on the other end? And this is something that I think we work very hard at Xandercardian, truthfully. So we have access to thousands of data points for heart rate and respiratory rate each day. And we had to think differently about how do you use that as a clinician and how do you digest that? Because it can't just be that now we're going to shift this overburdened clinician base to the community or to a remote monitoring center where they proceed to get burned out there, right? And ultimately, we need them to do more with less. And we have the ability to do that just through intelligent notifications. So we have something called a probability of change score. It's very simple, very elegant, and super effective at detecting early changes in somebody's condition. So I think you really have to think about who's receiving it on the other end and how can you actually effectively monitor a really large patient base. If you have 1,000 patients in the community, you cannot be using the old way of doing things. We can't use traditional alerts in that setting. It just doesn't make sense.
So I think part of the sustainability is definitely for patients is reminders. If you buy tech one time, forget it after 2 weeks because you don't have some sort of way of communication. And so I think the communication to the patients is very important. If you look at Medical Economics article back in 2020, they looked at about 20,000 patients and they said, how do you want to be communicated to by your healthcare provider? And the answer from this survey of 20,000 patients was a highly curated text message. So it could be, my secretary from Dr. Ali's office at Houston Cardiology Consultants wants you to do X, Y, and Z. And there were 3 asks from this group of patients for sustainability for communication. And the 3 were that they wanted to be able to text message to make or cancel an appointment. Number 2 was to do a prescription refill. And number 3 was to be able to acquire their medical records when and where they wanted it. So those were the 3 sort of asks by the patient population. So I think we always have to go back and do a needs assessment of what our patients are asking, not just what we think. Because I think looking at things at a 30,000 out view is not the way to do it. And the way to do it, I think, is you have to have people in the trenches. AJ, and practices, I practice in the trenches, and really communicate with the patients and see, what works and doesn't work, right?
Yeah, I think those are great points. I think one thing to consider, I mean, if you look at this, not specific to the healthcare field, but I think it's a year after an app's been downloaded, about 20% of people are still using it on a regular basis. So I don't know that the apps are the long-term solution. I think it's a tool, a gateway. It's a way of connecting and contacting patients. But you know, our program is a 10,000 patient study in hypertension and lipids in an outpatient population. I think what we're really trying to do is take what already exists in the healthcare team and make it scalable by adding in care providers that have lower resource that can be a much higher touch for patients, using tools like large language models and AI to make sure that patients have easier access to their healthcare team, and building those models in a way that you can reach that financial end goal of getting to value. So, you know, pay for performance metrics, working with population health management departments and payers to hit those intermediate goals so that, you know, eventually at a population level, if we control blood pressure and cholesterol, we know heart rates or heart attacks are going down, heart failure exacerbations are going to improve. We're not going to have as many people in the hospital getting decompensated, running up a lot of costs, and having a bad healthcare outcome. So I think what we'd love to do is partner with other institutions on that journey to value. And I think, you know, building a model that makes it easy for patients and providers to integrate into that and is financially scalable is really tough. But I think that's the needle we're trying to thread.
Yeah, I mean, you know, regarding scalability, I think a digital health solution is very, very scalable. I mean, there's 2 million people who have access to Hello Heart as a no-cost health benefit through their employer. I think engagement is, obviously, it's crucial. You know, 20% is probably about right. But I think through human-centric design, you can improve those numbers. So on the Hello Heart platform, 60% of members are still using the app after a year. But your last point was around health equity, and I think that's really important because I think digital solutions do have the promise of health equity. You know, AJ's research is unique in that a lot of telemedicine research initiatives have shown that they can actually exacerbate health equity gaps, where those members who have the greatest means, highest income, they tend to utilize telemedicine the most. AJ's research is unique in that. We focus a lot on health equity in our research. Last year we had a poster showing that clinical outcomes were the same regardless of age, gender, race, and preferred language of English or Spanish. And right now we have another poster that a colleague of mine is presenting. You can go check it out over in Area 3, looking at additional social determinants of health. Things like distance to a healthcare facility, urban versus rural status, household income. I think digital health solutions can be extremely equitable, and I think they're very complementary. I view devices and telemedicine providers and digital therapeutics as extremely complementary modalities, and I think, you know, there's 120 million people in America with hypertension. 80% of them are not controlled, so I think there's plenty of room for all of these solutions to contribute, and I think the best outcomes will come if we try to leverage all of the kind of the tools in our armament.
I would even take that one step further and say that if any of those are insufficient, the whole system comes crashing down. Right? You're only as good as the information you get, and you're only as good as what you do with that information.
Yeah, agree.
And we've identified health equity as one of the challenges to the future of using remote patient monitoring. And I'd like to hear from the panel around some other challenges that they see for the future of this work.
So, I mean, going along the lines of inclusion, I think is a very important part. There's a lot of sensors coming out that haven't really looked at all different types of skin colors and types and may not be able to actually penetrate different variations of skin. So it's a Fitzpatrick scale. There's 6 classes of the Fitzpatrick scale. And so I think there needs to be standardization for inclusion. And you're already creating inherent biases if you're not making sure that you're covering an entire population of different skin tones. So making sure that those Fitzpatrick scales, it should really be a standard of care in the research that companies are creating to make sure that they're also including diverse populations. So we're doing some research right now in Houston in NF500 using wearables and actually measuring Fitzpatrick scales. And also I would add both in elderly, in females, who are usually underrepresented in studies.
I mean, it's small things, but instead of, Bluetooth cuffs, we use cellular-based cuff as well as scales. It's a little bit more expensive, but some of these areas around equity and access, not all of our patients have Wi-Fi or Bluetooth-enabled devices, and even when they do, their tech savviness oftentimes makes it such that there's a lot more time and energy spent getting those devices set up. So, again, trying to make it, to beat a dead horse, simple, straightforward, easy, non-tech required, as few steps as possible to get people from engaged to sending data and working with us. I think those are the types of tenets that we try to follow. And the more seamless you make it, the fewer barriers you put in front of people, the more likely you're going to get people from all walks of life who can participate. We've showed that in our research, as my colleague mentioned. We don't require an app. We don't require Bluetooth or Wi-Fi. We use good old-fashioned telephone for the vast majority of our visits. We up to text message or email if somebody prefers. But I think you really have to go to that lowest common denominator. And in the vast majority of cases, telephone works for almost everyone. And I think using their native tongue is extremely important. I think making these solutions available to all is really that's going to be a huge barrier that a lot of us face. It's expensive to roll out in another language and have that done in a culturally sensitive way. But I think if you're really going to start hitting these metrics, your app can't only be available in English. Your materials can't only be available in English or Spanish. A lot of these people who have more challenges to accessing healthcare are not people who speak English or even Spanish in a lot of circumstances. In Boston, we've got 50 or 100 languages that are so it's a tiered response you have to have. It's not easy to go out with all languages or full cultural sensitivity and inclusivity all at once. But I think building towards that and making sure that you're lowering those barriers as opposed to just keeping them in place is important.
And I'll take a little bit of a different spin on this because I think our learnings are a little different because we are in the tech development space itself, right? So one of the things that we talk about, and it's more than just a buzzword, but we always say that we're changing the standard of care, and that really is our goal. And I think for us, one of the surprising and not so surprising challenges has been that because the device, ours in particular, is so good at detecting those changes early and detecting those, especially when they're very, very subtle. One of the challenges we've had is actually working with clinicians to so that they recognize the meaning behind those very subtle changes. So we're not looking at changes that are outside of that kind of quote normal range, and we are really looking to spin that concept of a normal range on its head, because what we know is that everybody is different and everybody has a different baseline. So for us, what we're doing is we're often seeing very subtle but significant changes in somebody's vital signs that are still within those normal limits. So now, as we bring those to clinicians, the challenge is always kind of getting past that notion of, a heart rate of 75 is normal. Yes, potentially, but it's also not normal for this particular patient. And I think for us, that's been an interesting challenge because as we talk to these clinicians and we start to see that, these changes happen 48 hours before the first symptom onset, how do we flag that as important, and how do we truly start to build that trust in the solution that we're offering? Because it's not easy. And in fairness, clinicians, and I'm sure the three of you up here can echo this, you're constantly getting people throwing ideas at you and throwing new technology at you. And the proof's in the pudding. And as somebody in this space, we have to prove it to you at the end of the day.
And I would love, before we transition to the innovation showcase, I would love to ask each of you very briefly to tell me what you are excited about enabling with remote patient monitoring.
Yeah, so, very briefly on the last question, the scalability issue is a real problem. Do we have enough providers to care for 120 million people with hypertension or 100 million people with dyslipidemia? Are we going to create fragmentation of care? If we have your doctor in the office and then a different doctor on the platform, and then there's a different platform in the office. What I'm excited about is just ongoing scale, getting this in front of more people. Our outcomes are very strong. Our financial and clinical outcomes show that digital solutions are a really important way to augment the traditional healthcare system, the providers who are providing care. The providers can dictate the care plan, and I think digital solutions can help patients stick to that care plan with medication reminders, prompts, different pushes. And I think there's a huge potential to address the tremendous unmet need of cardiovascular risk reduction.
I would say AI tracking of data, trends, changes, and hopefully using AHA care pathways to help patients go through the process of change, behavioral change.
I'll be really fast. Cuffless blood pressure, cuffless blood pressure monitors.
Okay.
I'm excited. We're just scratching the surface here. So I think there's a lot of good to come in the next 5-10 years.
Absolutely. And thank you to our audience and all of our panelists today for enlightening us on the promises and pitfalls of these types of technologies. Thank you so much. We're now going to transition to the Innovation Showcase.
So don't go anywhere. We are still continuing this lively discussion. And that was a wonderful panel, by the way. I think they touched on a lot of the opportunities, a lot of the challenges that we have ahead of us in RPM. So I'll continue the discussion, and we'll certainly have time for a bunch of other folks as well. So my name is Ben Green. I lead clinical services at AliveCor. I'm a family physician by background, and I started my clinical career back in 2007 doing home visits. Doing house calls, which is a kind of an antiquated way to practice medicine, but a really fantastic way to really meet patients where they are. And when I think about telemedicine, let's see if I could figure this out. Oops. We'll get there. Dr. Dave, I don't think I need slides. All right, here we go. Thank you. So when I think about RPM, I sometimes think we're going back to the future. So we're here in 2023. This is a cover story from 1924. So they were predicting the future of medicine, and here we are 100 years later. We're finally there, sort of. Why does it matter? So I think our panelists really touched on this, but what we're offering to patients is really life-altering and life-saving solutions. This is a quote here from the AMA's Remote Patient Monitoring Playbook, which came out in 2022, which really speaks to the opportunity we have to really truly save lives and transform lives. I'm going to talk a little bit about cardiac remote monitoring and ECGs in particular. If you look at the technology behind ECGs, it has not fundamentally changed significantly in over 150 years. Certainly the form factor has changed, which I'll get to, but as we can see, Willem Einthoven's original ECG machine back in the early 1900s, the principles are pretty similar. Fortunately, the form factor and the applicability to home use has changed quite significantly. So this here are the AliveCor and Cardia suite of mobile ECG devices. If you look at the left-hand side of the screen, this is the original one-lead personal ECG device, which came out in 2012, still being used today. The 6-lead version came out in 2019. Certainly an ability to provide more information, more data to doctors who are monitoring patients remotely. And then most recently, a new form factor in the form of a credit card, again, for personal ECG monitoring at home. As we look at the opportunities in remote monitoring, specifically related to cardiac monitoring, I think the panelists already spoke to a lot of these, but certainly there are opportunities for incremental revenue, and I'll get to that in a sec. Improved outcomes. So certainly there's tremendous applicability to really moving the needle on earlier diagnosis, earlier identification of outcomes that can lead to deleterious effects. Reduce system costs. I think Dr. Blood really spoke to the fact, as we move to value-based care, as we move to not just adding revenue to systems, but reducing unnecessary healthcare costs, really this is a tremendous opportunity, and I'll show you a little bit of our impact in that area. And then last, but certainly not least, is patient satisfaction, patient loyalty. Patients now are looking for solutions to help them at home. They're looking for providers who are going to help them manage themselves at home as well. So certainly patient loyalty is something we come across a lot. Some of the challenges, again, we've touched on it here with the panel. We hear it a ton: data inundation, data disorganization. As a doctor and doctors we speak to, they don't necessarily want all of this data coming in from all of these different disparate sources. People bringing in papers, people emailing data, people sending it in through potentially their EMR, but usually not. So how do we fix that? Path to revenue. So although there are revenue opportunities, it's not so straightforward, as we've already touched on. 16 days of data, and there's all these complexities for billing appropriate CPT codes. And then the operational overhead to handle all this data that's coming in is certainly a challenge. Some of the use cases, and just being mindful of time, as we think about remote monitoring in the cardiac area, the use cases that we're most focused on: longitudinal management of arrhythmias, post-ablation monitoring, post-surgical monitoring, QT interval monitoring, certainly an increasingly important issue for cardiac and non-cardiac meds, AFib screening as well. Some of the outcomes we're quite proud to see is that our devices do lead to reductions in unnecessary inpatient and even outpatient services. So this study was done by folks at Jefferson here in Philadelphia that showed significant reductions in arrhythmia-related ER visits and hospitalizations. Some of the revenue opportunities, I'll just say here, be creative. It's not only about the RPM codes, the RPM CPT codes. There are a bunch of other opportunities to bill for fee-for-service opportunities in RPM. Post-ablation, really another area that we're seeing a tremendous use for monitoring patients, not just in the short term, but longitudinally. And then this is a really exciting new opportunity for QT monitoring, home sotalol loading. So this is a group at Ohio Health. They've now transitioned their inpatient loading program to completely outpatient loading using a CardioMobile 6L device to measure the QT. And then, I think we talked about bringing the data into the doctors, organizing it into doctors' workflows, not creating a new panel as Dr. Blood, or a new portal, as Dr. Blood said. So we are proud to announce a partnership with GE. So our data, the 6L data, does flow directly into GE Muse systems. So now doctors, cardiologists who are already familiar with the Muse system can view this data that's being collected at home directly in their existing workflows. And at the end of the day, it's all about the patients. We have over 85,000 reviews that we look at all the time to really inform how we build our products for human-centered design, as Dr. Paz mentioned. So certainly proud of that. And I know I'm way over time, so I'll hand it over to our next speaker. Thank you, guys.
All right. Very excited to introduce my distinguished colleague, Maurice Nassim. I'm going to be co-speaking with him. I think he's the first speaker at these sessions who's a geophysicist, and he's not just any geophysicist. I'll explain about that in a minute. I know the topic is the business model of remote patient monitoring. And when we think about remote patient monitoring, we usually think of vital acquisition and EKG acquisition. But one thing that we haven't talked about is the #1 imaging modality in cardiology today that's non-invasive, which is echocardiography. And we know there's a lot of tech around echocardiography. And Maurice is here to talk about something very unique, which is his background. He's the past president of Schlumberger Seismic Imaging with multiple patents. And the technology in the world where we look at oil and gas using seismic imaging came from him and his colleagues, including Nick Malvinato. There's a very big parallel in oil and gas and cardiology, and I hope you'll see the parallels of that when Maurice gives his talk on seismic imaging and a technology transfer into ultrasound imaging. Thank you.
Thank you, Dr. Asif, and thank you very much for the American Heart Association for the invitation to come and talk today. As Dr. Asif said, I am a geophysicist, so I'm not a cardiologist. I've been working for quite a long time in that field, and would like to share with you some ideas about what can be transferred technology from geophysics and oil and gas and energy into the medical world. So this is what we're saying. We're saying, how can geophysics contribute, do quite a big revolution related to medical, starting by imaging. And imaging actually is quite an important factor there. I'll show you a quick video that hopefully is going to give you a little bit of an idea about what I'm talking about.
By improving the clarity of what can be seen, it's been said that seeing is believing. By improving the clarity of what can be seen, we at Cloudstream Medical Imaging are transforming belief into reality. The world spends over $8 trillion on healthcare every year. We're throwing more money and more technology at a condition that's not getting better. And we wait. Reaching the limits of a flawed approach, we treat sickness instead of preventing it, growing sicker in the process. And we wait. Prevention requires earlier and more accurate diagnostics, which requires detailed imaging and specialists to interpret or misinterpret. Still, we wait. Meanwhile, we ask, is this as good as it gets? The same question asked by the oil and gas industry 20 years ago, when hard-to-reach hydrocarbons demanded innovation in subsurface seismic imaging. Billions of investment dollars advanced signal processing and noise reduction, allowing us to see through previously impenetrable geology, revealing insights miles underground. It changed the industry and the world. Today, Cloudstream Medical Imaging is poised to revolutionize healthcare as the first to apply those same advancements to diagnostic sonography. Decades of established innovation on an accelerated timeline to upend the status quo. Imaging can be securely accessed through the cloud by doctors and patients anywhere in real time. The computational power unleashed by cloud-based GPU technology and 5G networks makes what was once impossible possible. And with Cloudstream Medical Imaging, it's far less expensive since users only pay for active processing time. Our high-resolution sonography will also enable artificial intelligence and machine learning for safer, more accurate, and more actionable diagnostics. The wait is over. High-quality imaging can be anywhere, hospital, office, or field, enabling real-time collaboration between EMTs, radiologists, and other physicians, saving time, saving money, saving lives. A truly disruptive innovation that accelerates successful advancements from the oil and gas industry to the medical industry, enabled by the GPUs and cloud technology revolution. Introducing the advanced 4D ultrasound transducer that becomes the gateway to the first real ultrasound cloud, with advanced GPU processing and artificial intelligence delivering real-time access for all key stakeholders. It's the first step to enabling a human digital twin for everyone for full lifecycle management, transforming healthcare forever. Seeing and believing with unprecedented clarity.
Okay, so I'll go quickly through why is oil and gas and seismic methods for finding and exploring for oil is similar to, or has some similarities with medical. So first, I'm showing here the sources and receivers that we use in seismic. And then similar, there are also sources and receivers in ultrasound that's used in medical. The difference, of course, is the frequency content of the sound. Now, the physics is the same. There is no change in the physics dramatically, but, you know, we're looking at very, very deep into the reservoir, trying to find where the oil and gas are. And of course, in ultrasound, we're looking at something different and quite complex also. Now, the advantages, all of you know as cardiologists, you know, of the echocardiograms, and it's the workhorse of cardiac imaging. Now, the question is, you know, what are the unmet needs? What are the difficulties that we are facing? So, a very important one is cannot see through the ribs. Ribs are bones, and they are very difficult to get sound through them, similar to something I'm going to show in oil and gas called salt. Salt bodies are very similar, and I'll show a little bit about that. Plus also the inconsistent resolution and also the other challenges that you are very familiar with. Now, bear with me a little bit here because that's not the heart, that's the earth, that's the subsurface. So please bear with me a little bit. So here I showed where the water bottom is. So this is the earth. Think about this as a cross section in the earth. This is the water bottom. This is the top of the salt. Salt is, you know, one of the materials that are very important in oil and gas because it's a very good cap of the oil. So it's very good for trapping. But what we're interested in is what's beneath, what is really under that, which is the unseen here. This has been a problem for more than, lots of years. Only 15 years ago, we were able to resolve this by coming up with new technologies that's able to see beneath the salt. I'll show you now the image after that technologies. You can see here that beneath the salt, you can see very, very clearly all the targets. You were able to drill there successfully and find the oil and gas traps that we're looking for. And that's through technologies related to what we call wide azimuth and what we call full azimuth to be able to see an undershoot under the salt. And that's the same technology that I'm going to propose now in one slide coming up. Okay, here is a synthetic model that we're looking at. This is closer to the body that's used by lots of scientists. And it shows the bones at the top, and then it shows some features and lots of details. And here, our standard echo, where we're using the standard probe, where we're putting it between the bones and pushing, it's a small one. So you see how difficult it is where it's very narrow at the top and also in the middle, and then deeper you see much, much less resolution. With the new technology, which is mimicking some of the technologies in oil and gas, you're able to see lots of detailed resolution and ability with clarity, and it's become very similar to the model. So that's quite significant. And finally, my last slide showing that in echocardiogram, we're saying that, okay, we have problems, but in the same time, we have another field, another industry that you can borrow some technologies from. So first challenge, inadequate resolution and clarity using GPUs, cloud, and integrated platform that is currently not being used in the medical world. And that has been implemented in oil and gas for more than 10 years now. So that's an area where there is lots of work that can be done and successes that can be shared. Second is related to, till now, the usage of constant velocity is for everything, for bones, for blood, for water, for tissues, assumptions in echocardiograms. Of course, there are some more advanced technological equations that can be used that also need some high-performance GPUs. Last one, and not least, I think it's the most important, illumination behind the bones. Rather than having to push between the bones, you can do it at the top and be able to see with special design for those probes and technologies. Thank you very much for your time.
Hello, I'm Jeff Bennett, the CEO of Higgy, and now also the Chief Strategy and Innovation Officer at Motive Care. Thank you for having me today. I'll try to run through these slides relatively quickly because I know we're on a tight time frame. First, introducing where our context comes into around remote monitoring. Motive Care is the leading provider of integrative care for people with complex health conditions. We deliver over 30 million rides to people that need access to a doctor's office or a dialysis center. We deliver personal care, ADL in the home. We deliver remote monitoring for those that need connection, whether it's a Vitals device or a PERS device. And we also have digital engagement solutions that are scaled through the communities across the country. So what this really means is we have a way to address the unique needs of individuals based on their conditions. If you look at the far left, Louise, who's 55 years old on Medicaid, she's pre-hypertensive and pre-diabetes and has hypertension. S2H needs around lack of access, doesn't have time to go to the doctor, needs food, to going all the way to the far right, which I don't read all these things, to Michael, who is living with chronic kidney disease, probably end-stage renal disease, is getting 3 rides every week to the dialysis center and has much broader needs. So we come into that context of getting the right monitoring solution as a tool, as a signal to manage the needs of the individual population. And fortunately or unfortunately, depending on how you look at this, we're there to provide excellent care and meet the needs of that member and that patient, but we're also in the business of healthcare. So if you don't understand how our customers, which are DSNPs, Medicaid plans, states, Medicare Advantage plans, make money, then we're not going to help them in this whole picture. So these are the 3 or 5 key things. You need to identify needs that are there and make sure they get appropriate coding, because the plan needs to get paid for the acuity of the member that's going on. We also own 44% of a company that does home visits called Matrix Medical. Drive quality measures for the plans, manage individuals to avoid avoidable hospital visits, ER visits, improve member satisfaction, a key quality measure now with CMS, and finally drive patient member acquisition and retention. This slide is an important slide to understand. So on the far left is this year. The far slide on the right is next year. The key on here is from the data from a research report that we found that was actually with another PERS vendor, is only 25% of the people that are high risk this year will be high risk next year. 50% comes from the mid risk and 25% comes from the low risk. So if you're working with customers that are taking risk, you can't just focus on the high risk because you're going to be missing 75% of the population next year. So you need to build scalable solutions to reach all the populations, spread your dollars towards the high risk this year, but find the people that are going to be there next year. So what do we do? How do we solve this as an industry? You need to continually assess risk, triage, provide a service that's appropriate, and monitor, do it all over again. And what this means is a platform that, I'll build this out from a time perspective, that goes omni-channel to engage everyone no matter your level of acuity, digital access and education, working closely with AHA to get that validated content out to the members, BYOD, all the way up to the top in home care. So this is the level of services that you need to provide to avoid the woman on the left, because right now she's getting 5 different vendors calling her with 5 different solutions. None of those are organized. The doctor's frustrated, she's frustrated. You actually need to put a in-person or a virtual or a digital advocate in the middle there to help that patient, help that doctor drive better outcomes. So that's effectively what we believe that you need to deliver scalable RPM. To implement this isn't just to build a solution. You actually have to know how to implement this to reduce all the friction within the hospital system or the care management system within the plan. You need to make sure when you onboard, you mitigate changes in workflow and make sure you understand what the member needs, the provider needs, and the plan needs. And finally, several things, just in terms of time, because I know we're pushing on time, then you get into all the things we just talked about. Now you actually have to engage the patient on a longitudinal basis. So don't forget about those first two things, because you can't get through those first two things, you're never going to get to the end, because you're not going to get any doctor to recommend this to their patients. So in closing, I think our goal is better outcomes, the quadruple aim, obviously. I saw this earlier. It's bringing the consumer experience of big tech, understanding the business model of healthcare and plans, access of retail. I mean, I say retail, not just pharmacy, but how do you meet someone in the community where they are? And we're heading towards a model of patient-centered, holistic care. And I think when you get down to the pricing models of these things, fee-for-service isn't how this should be solved. This should be understanding what the patient needs and show that you can do shared savings. Or some organizations are taking global risks, it's fine. But you have to get to the point where you're showing value. That's where we're really heading. Thank you.
Let's see if we can get our slides up. So I'm Zane Arp. I'm here from the government. I'm here to help you. Words made famous by President Reagan. I hope at the end of this talk, everybody here is in agreement that there is some things, or are some things that the government can do to help out medical device development. Let's see. I still don't have slides. Do I? Oh, there we go. Perfect. This is a slide I start with every talk I give. It's really the 7-word summary of what the agency or CDRH's summarized mission is: reasonable assurance of safety and effectiveness. So, everybody here will agree safety and effectiveness is a very important thing. We need to hit that. The real question always becomes, what's reasonable? So Dr. Ali today in the panel gave me a great primer in this for this talk. The use of Fitzpatrick scale for skin color determination. Should it be used? The question is, was it ever developed for it? So if you look at the Fitzpatrick scale and you go back historically, it's utilized all the time for determination of skin color in different clinical studies. It's commonly used, but it was never developed for that purpose. It's actually a skin color method to determine whether or not you're going to have a suntan, get a sunburn. It's UV determination. So it's never determined or never utilized or never developed for utilization in the current format that it's utilized today. Question becomes, is that reasonable whenever you bring in a study? You got your new light-based sensor that's going to have, effects from skin color. Is this what you should utilize for the purposes of, I apparently hit a button, for the purposes of determining skin color? And the answer is, depends on what you consider to be reasonable for that study. Maybe you need something more with more resolution that provides more groupings. Maybe Fitzpatrick's just fine. The question is, which one's right for the studies that you're doing? And that's where we step in. We work in the Office of Science Engineering and Laboratories on regulatory science, which is the science of demonstrating safety and effectiveness. And we are putting out things called regulatory science tools now to help medical device developers bring their devices to market through better tools in the space of reasonable assurance. Up on the screen is an example from our regulatory science tools catalog. This one is a toolkit for evaluation. Let me see. This is a tool for evaluation of head-mounted display monitoring units. This is a commonplace issue where you got to make sure that your device is working correctly, that you have a tool in place to determine the image quality before you actually put it out on market, before you come to the agency. We've actually put this out. We've done science. We've looked at the methods. We have evaluated that. We've published on this. And now what we're trying to do is take those publications and put them out in a format where they're easily replicated by anybody in the medical device space who wants to use them. These are not regulatory grade. I will put that up there up front. These are the best science today that we're aware of, and we're trying to make it something you can replicate and easily utilize in your studies. We have a variety of different regulatory science program areas. I put this up on the screen because I can't go through all of them today. I'm using one very brief example for the purposes of this talk. This is the areas that if you go to our regulatory science tools catalog, you can find a variety of different tools in. And then my next to last slide is, you can take a picture. These have QR codes of various ways that you can interface with the center, with the office to further evaluate the research we're doing, ask questions about these, get involved with the regulatory science mission of the FDA. And that's it. My slides, I've somehow moved it forward all the way through. Thank you, and I'll give a minute back.
Okay. Good morning. My name is John Anderson. I'm with BioBeat Technologies. I'm the head of sales for the U.S. Primary focus is ambulatory blood pressure monitoring, but also supporting various RPM applications that we have throughout hospitals within the U.S. So we're trying to answer a difficult question, and we heard a great panel discussion on creating scalability and sustainability within the business of RPM. Not many, honestly, really have figured it out, and we've seen that within the patient volume, and the adoption's been slow. So what BioBeat has provided is answering some of these challenging questions. So really the biggest obstacle that we hear from physicians is they want actionable data. So they want data that will allow them to make quick decisions that will improve the overall care. They need it to fit directly into their workflow and not add additional work. So it's got to be easy for them. And then we have to do all of this at a low cost. So what BioBeat has done is they provided more actionable vital data than any device on the market. So right now, I'm over there. My vitals are streaming. I've got a chest patch on. My vitals are over there on the screen. My blood pressure is probably up through the roof a little bit. But you can see here, this is all the data that we're bringing in. So we're bringing in medical grade data on a proprietary chest patch device and our proprietary cloud-based software. We have these applications all throughout the US in health systems like Mayo Clinic and Ochsner. So there's many different applications for this technology. We have scenarios like, think about inpatient monitoring. No longer will you have to go in and manually check your patients. You can have a chest patch on a patient, all the vitals will be streaming in, and the nurses, it'll come into a central nursing station, the nurses can triage appropriately. So we're reducing labor, reducing costs in those settings. We also have short-term applications, so think about discharging. We have a package where you can monitor patients for just 5 days with one single device, bringing in all the vitals you see today. No longer will you have to have 2, 3, 4 devices to monitor patients for sepsis or CHF, hypertension. We also have long-term applications. So you can use our watch for long-term hypertension management to monitor patients for 6, 12 months and beyond. We partner with some of the best companies in the nation, like Best Buy, to help support how they're going to back-end support the technology from a long-term RPM standpoint. But what we're doing, I think that's the most impressive, is we're changing how ambulatory blood pressure monitoring is being delivered today. And I'll get just a little deeper into that in a second. So BioBeat has 13 vital parameters coming in off just one device, and more are being added. So today, we have 7 FDA-cleared vitals that are coming into the chest patch. We have 3 FDA-cleared vitals that are coming into the watch. We have cuffless blood pressure on both devices. BioBeat was the first FDA-cleared cuffless blood pressure device that's analyzing through PPG analysis. We have our wrist monitor and our chest patch. Either or all come into our proprietary cloud-based software. But I want to go a little deeper into what I think is one of the most impactful things we're doing today. So today, you have an ABPM service that's with a 24-hour cuff-based device. The patient has to wear this uncomfortable cuff device. It's labor intensive. Patients oftentimes aren't compliant. They take it off or they just don't do the service from the start. For that reason, many physicians have pushed this aside and are not using it today. So what we're doing is we're changing the market just like other companies have in other devices. Think about 24-hour Holter monitoring, how ZeoPatch came in, BioTel with ePatch, Barty with CamPatch. They came in and they replaced the uncomfortable 5-lead Holter and gave a simple patch solution. So we're doing that with a very easy service. We give you kits on consignment. You put the patches on. The patient wears it for 24 hours. The data is transmitted automatically to the physician's portal. There is no waiting for reports. It's immediate. The patient then takes off the device and throws it away. There's no coming back to the office. So now a patient has a much better solution, better information, better workflow, and better overall patient experience. And by the way, the data we're delivering is more powerful. It's 96 readings versus 32. It's correlating other vitals like cardiac output. We really believe this is going to change the way hypertension is managed in the market. So if you're interested, please go to our website, bio-beat.com, or simply just come right over to the stand and visit me. Thank you so much for your time.